known for his patient-centric approach and active involvement in community cancer awareness initiatives. We look forward to his talk. Sir, over to you, please.
Thank you, and very good evening to all the respected faculties here. I am going to share my screen. I'm unable to share my screen.
Kindly try it now, sir.
Still, the share link is not active.
You want our team to share the PPT, sir?
No, I'm sharing it. So I have shared it. Now, is it visible?
Yes, sir. Yes, sir.
A very good evening and warm welcome to all the respected faculties who have joined here. Myself, Dr. Sachin Sekhar Biswal, and I will be speaking about resectable EGFR mutated lung cancer. As such, the data says that the incidence of EGFR mutation in the Asian or Indian population is high. When the global data stands at 20 to 25%, Indian data in some data sets it reaches from 30 to 50% itself. And again, while the incidence of EGFR mutation is very high, the number of resectable lung cancer cases that we get are very, very low. I have completed 3 years at Bhubaneswar and I have only seen 2 cases of resectable lung cancer till now. So, while we find resectable lung cancer and we test EGFR mutation, again, there is a time gap when to test. So, we will be discussing about why it is important to test for EGFR mutation and what is the standard of care or where we are headed in resectable EGFR mutated lung cancer. As we discussed, there is a high prevalence of EGFR mutation in Indian or Asian population. And despite the standard of care treatment, that is surgery and adjuvant chemotherapy, that was the historic standard of care, the recurrence rate remained quite high, ranging from 30 to 60% in stage 2 to 3A. And while we routinely practice chemotherapy in adjuvant setting with platinum doublets, the benefit of this adjuvant chemotherapy was really modest. The overall survival improvement was 3 to 5% only. And despite of the OS benefit, the PFS benefit was lacking, and especially the CNS benefit, it was lacking, and there was a high risk of CNS relapse with adjuvant chemotherapy only. So, what do we consider as resectable non-small cell lung cancer? Stage 1B to 3A, we consider it as resectable lung cancer, and where the feasibility of R0 resection is there, and the patient has adequate reserve or cardiopulmonary reserve to undergo that surgery. And molecular profiling, it is mandatory. And multidisciplinary meeting, I am sure we all practice, and this decision of a surgery for a resectable lung cancer is tumor board driven. When we call about EGFR mutated resectable lung cancer, we are strictly talking about the sensitizing EGFR mutations, that those mutations that are sensitive to EGFR tyrosine kinase inhibitors. These most commonly, more than 95% of the cases are exon 19 deletion and exon 21 L858R mutation. There are less common mutations also there, and exon 20 insertion mutations are not eligible because it works at a different pathway. Uh, Coming to the historical standard of care, the primary treatment was surgery, adjuvant treatment was platinum doublets, and the benefit was modest. And there was a unmet need in this EGFR positive population due to high rate of local systemic recurrence or CNS recurrence. So a lot of early trials were there which were evaluating the uh, possibility of adding a EGFR TKI for improvement in DFS and OS. Most of these trials, as we know, trials of erlotinib are there, which are Radiant and Select trial. Select was a North American trial, and it was a single arm trial in which erlotinib was given for 2 years, and the DFS benefit of 5 years, it is not reached, or the OS benefit is not reached yet. There were a lot of criticism to this trial being a single arm trial, and there were a lot of dose modification due to toxicity, classical toxicity of erlotinib, that is rash and diarrhea. And the patients were eligible in this trial to be enrolled in this trial up to 9 months of surgery. So this is not a very standard trial which can guide us further. Radiant is also a trial of erlotinib in which erlotinib versus placebo it was given. There was a definite improvement of PFS. There was a definitive improvement of disease-free survival in Radiant. Similarly, Corin, Evan, and Adjuvant, these are popular Chinese trials of erlotinib and gefitinib. Impact is a Japanese trial of gefitinib, and Evidence is a trial of icotinib for 2 years. But when this ADURA trial came, that is the adjuvant osimertinib trial for 3 years versus placebo in resectable lung cancers, the benefit, it was tremendous because the DFS gain, that was 65.8 months versus 21.8 months, and the hazard ratio was 0.22. And this benefit was found in all the populations, irrespective of the patient is a male or a female, irrespective of level of PDL1 expression. And the response, it was sustained also in the CNS relapse. So this became the standard of care. So in the next few slides, we are going to discuss about the ADURA trial. So coming to this ADURA trial, which is now the standard of care for adjuvant EGFR mutated resected lung cancer in patients completely resected 1B to 3A non-small cell lung cancer. The inclusion criteria was more than 18 years, confirmed sensitizing EGFR mutation, and brain imaging. It has to be done before randomization, and complete resection, that is R0 resection. And the maximum interval between surgery and randomization, it was 10 weeks if the patient is not going to receive adjuvant chemotherapy, and maximum 26 weeks if the patient is going for adjuvant chemotherapy. So this was stratified, and it was randomized. The two arms were osimertinib versus placebo. The treatment, it was continued until disease recurrence, or the treatment was completed, or the patient was discontinued. The primary endpoint was disease-free survival, and the secondary endpoint was disease-free survival in overall population. The baseline characteristics, as we can see, it was matched in both the arms, osimertinib and placebo arms. The number of patients receiving adjuvant chemotherapy, it was also similar, and the number of patients having the sensitizing mutations of EGFR, these were also similar. So coming to the primary endpoint, that is the DFS in stage 2 or 3A, the disease-free survival with osimertinib, it was 65.8 months versus placebo, it was 21.99 months. The hazard ratio was 0.23. So this benefit of osimertinib, it was unlike any other previous trial, and the benefit was very clear cut, and it was by a huge margin because the correct patient selection. The updated DFS in overall population, as we can see, the hazard ratio is 0.27. Across all the subgroups, the benefit, it was sustained, irrespective of stage, age, smoking history, race, or EGFR mutation status, or adjuvant chemotherapy. This benefit, it was sustained across all the groups. This is an interesting curve. These three Kaplan-Meier curves, they account for starting from stage 1B to stage 3A. As we can see, the hazard ratio, it is best in stage 3A. So the benefit, it was increased with the increase in the stage of the resectable cancer. And the OS data that is available now, it is the for osimertinib, it is 88% 5-year OS rate versus 78% for placebo arm, and the hazard ratio for OS is 0.49, which is significant. So now it has both DFS and OS benefit. Coming to the CNS DFS in patients with stage 2 or 3A disease, the CNS disease-free survival, it is not reached in both osimertinib and placebo groups, and the hazard ratio is 0.24. So considering all this, we now know that for sensitizing EGFR mutations, patient undergoing surgery from 1B to 3A, osimertinib is the standard of care. It is to be given for a period of 3 years, and the benefit that is sustained across all the subgroups. Coming to neoadjuvant approach. For considering neoadjuvant approach in lung cancer, that is a lot of data, a lot of ongoing research is there. But these are the main hindrances that that makes the neoadjuvant therapy selection difficult for resectable lung cancer. That is the time of driver mutation testing, when to test the driver mutation. As we discussed that standard of care is osimertinib after resection, and while considering resection for a EGFR mutated lung cancer, the tumor board should be involved, and I consider this to be more of a molecular decision, when to get the patient operated, and when to start the osimertinib. The high PDL1 expression status. If the PDL1 expression is high, it is also a confounding factor while selecting neoadjuvant therapy. And nowadays, when there are a lot of immune checkpoint inhibitors are available for neoadjuvant approaches, the EGFR mutation status may not be taken into consideration. So again, this should be discussed in a tumor board, and EGFR, I think, supersedes the PDL1 status. The presence of uncommon mutations in EGFR also makes it difficult to select the neoadjuvant approach. The presence of co-mutations along with EGFR. So this also makes neoadjuvant therapy difficult. The possibility of adjuvant immunotherapy after surgery, and any reliable endpoint of neoadjuvant therapy. What should we consider an optimal endpoint for neoadjuvant therapy? And if we give neoadjuvant TKIs or osimertinib, then how do we treat the patient at progression? These are the factors which are roadblocks in deciding the neoadjuvant approach for lung cancer. Again, there are a lot of neoadjuvant trials ongoing. Out of that, the promising one is the NeoAdjuvant trial, which is in which neoadjuvant approach for resectable lung cancer with EGFR mutation has been taken. Resectable stage 2 to 3B EGFR mutated lung cancers has been taken. It is a 3-arm study in which placebo plus chemotherapy is 1 arm, osimertinib plus chemotherapy is 1 arm, and single agent osimertinib is another arm. So osimertinib has been used with or without chemotherapy, followed by surgery. The primary endpoint which has been taken is MPR, or a major pathological response, and followed by the adjuvant investigator's choice. The trial is still ongoing and the data is not available. A short while ago, the patient reported outcomes were available and it was quite promising. And also, they have included in this minimal residual disease monitoring. That is, after surgery, they monitor the circulating tumor DNA level, and it is considered as also as a important predictor of response to EGFR therapy. This trial looks promising, and in the coming days, the outcomes of this trial will guide us to choose wisely. Thank you.
Thank you, sir. Thank you so much for your informative session. So if any of the participants is having any queries, kindly drop the queries in the chat box so that we can take it forward. I guess there are no questions, sir. Thank you. Thank you so much for your time. So, without an ado, we now move on to our next session. I would like to invite Dr. Arun Supreet, sir, a consultant medical oncologist at Sri Shankara Cancer Hospital, Bangalore. His clinical practice involves the management of solid tumors with research interests in geriatric oncology, breast, and lung cancer. He is actively engaged in postgraduate teaching and committed to evidence based, patient centric, and ethical oncology practices. Sir, over to you, please.
Thank you, IAO team, for giving this opportunity. And I'm happy to be presenting my talk on stage 3 unresectable non-small cell lung cancer, focused on for sequencing chemoradiation and immunotherapy, along with newer immunotherapeutic strategies that are coming up in this space. Can you please share? Can I share my slides?
Yes, sir.
Yeah, so I hope my slides are visible.
Yes, sir.
Yeah. So there are some fine changes that have come up in the latest AJCC staging in non-small cell lung cancer in the 9th edition. Just to quickly revise what is the T staging in the AJCC staging system. We know T1A, T1B, and T1C are very early stage diseases without any spread or involvement of the chest wall or pleura. While T2A, T2B, we see involvement of the visceral pleura, we see involvement of the primary bronchus before reaching the carina. or with the tumor size more than 4 centimeters. Then you have T3, where the disease is infiltrating smaller blood vessels towards the mediastinum, phrenic nerve, or pericardium. And if you look at the size criteria, 5, 6, or 7 centimeter sized lesions will be considered T3. Then direct infiltration of parietal pleura or extension into the thoracic nerve roots or stellate ganglion will make it T3, or separate tumor nodule within the same lobe as the primary. So these are all T3. Then you have T4 disease, which is a very large tumor, more than 7 centimeters in size, or a tumor that is reaching the carina, or tumor that is directly invading great vessels of the mediastinum, directly invading the trachea, superior vena cava, diaphragmatic invasion, or infiltration of the vertebrae. So these are the tumors that would be considered as T4B. Now, coming to the nodal staging, this is where the difference in the current AGCC classification can be seen as compared to the previous one, especially with focus on N2 staging. This is important because N2 single station involvement will be considered as a resectable lung cancer, while N2B, which is multi-station involvement, right? If you can see in the image, we can see right paratracheal lymph nodes and subcarinal lymph nodes are involved, and this becomes a multi-station N2 involvement, and that makes it an unresectable non-small cell lung cancer. So at least to begin with, unless you give some form of neoadjuvant therapy to downstage it, and then you can take up the patient for surgery, or it will directly be a case of definitive chemoradiation. Now, we also know N3 is involvement of contralateral hilar lymph nodes or mediastinal lymph nodes, or both ipsilateral or contralateral, either ipsilateral or contralateral supraclavicular lymph node involvement. These are the various lymph node stations. This was the change that I was talking about. N2 is classified into N2A, which is single station involvement, N2B, which is multi-station involvement, which was not the case in the previous TNM classification, which was kind of a problematic area to determine resectability, because the moment you say N2, nobody could clearly say whether the disease is resectable or unresectable. Now, with this staging system, you can clearly do that. Then you also have a difference in metastatic staging. Now, newly introduced stages of M1C1, which is multiple extrathoracic metastasis in single organ, and multiple extrathoracic metastasis in multiple organs is also added. And this is mainly to see if the disease is confined to a fewer vertebrae, 2 adjacent or 3 adjacent vertebrae, it would still be eligible. The patient would still be eligible for some form of local therapy to the vertebral column after giving a test of systemic therapy. And anyway, that is out of the context for our discussion today. Now, if you see, all the stages that are mentioned within the red box are the candidates for definitive CTRT. This is just to highlight the fact that just because the stage is mentioned as stage 3A doesn't mean that the disease is resectable. There are some of the subsets of patients with stage 3A who are still unresectable and become candidates for definitive CTRT. For example, you have a T4 lesion which is involving the mediastinal great vessels. These patients are not for resectable or not considered as resectable lung cancer patients. Similarly, you have multiple ipsilateral separate tumor nodules in different lobes. Again, these patients, unless they are fit enough for pneumonectomy, they would not be candidates for resectability. Then stage 3B, we all know it is borderline. These patients can either be resectable or unresectable. But again, in stage 3B, as I was mentioning earlier, there are certain categories of patients who are clearly unresectable right from the beginning. And stage 3C remains unresectable right from the beginning. Though this is survival based on the stage, it is based on older data. As you can see, even within the subtypes of or subcategories of stage 3, the survival drastically reduces. Stage 3A, for example, has an overall survival at 5 years of 36%. 3B it is 26, and 3C is 13%, which is more or less this is same as advanced stage non-small cell lung cancer. This is the importance of the stage 3A, 3B, 3C classification. Now, stage 3 disease, as I was mentioning earlier, it is a varied entity. You have clearly resectable patients on one spectrum, and on the other end of the spectrum, you have patients who are for palliative therapy or for definitive chemoradiation. That depends on various factors, which some of which are these. So if you can see, those mentioned within the red box are the ones who are clearly unresectable and would go for definitive CTRT. For example, somebody has a very bulky disease, tumor size is more than 7 centimeters with multi-station N2 involvement, or somebody with invasion of mediastinal pleura or pericardium or great vessels or superior vena cava. Though technically these patients have T4 disease, it would still be non-metastatic disease, they would still be candidates for definitive CTRT or for palliative systemic therapy. Or as I was mentioning, contralateral hilar plus mediastinal lymph node involvement, or superior sulcus tumor, where the tumor is involving the sympathetic chain, or it is involving the great vessels again in the mediastinum, would be the candidates for definitive CTRT. Now, these are all the patients who are classified whether resectable or not resectable purely based on surgical feasibility. Now, there are certain medical reasons which make the patients inoperable rather than unresectable. So the difference being inoperable means patients with still a technically resectable disease, but because of various medical reasons such as poor performance status or multiple comorbidities or COPD with poor lung reserve, these are the candidates who become inoperable, though they may have a technically resectable disease on imaging. Now, what are this is how we understand the impact of staging and various other factors on patients' disease becoming resectable or unresectable or becoming operable versus inoperable. Now, what are the staging essentials for stage 3 non-small cell lung cancer? Definitely, we need PET-CT to rule out different, distant metastasis. We need to do a contrast enhanced MRI brain to see if we are not missing out any asymptomatic brain metastases, and we need to do a tissue molecular testing. This is very important because even in stage 3 now we have role for maintenance osimertinib in EGFR altered patients, or role of alectinib in patients with ALK rearrangements. So this is important. At least EGFR ALK testing becomes important in stage 3. And of course, PD-L1 IHC. This may not play a very major role here because regardless of PD-L1 score, we are going to offer adjuvant or maintenance immunotherapy in these patients. But still, there is some data to suggest that patients with PD-L1 positive status, that is score TPS more than 1, are more likely to benefit from the scale of benefit is more as compared to those with PD-L1 negative status. Now, when is mediastinal staging needed? So when I say mediastinal staging, as such, I mean either mediastinoscopic staging or EBUS plus EUS guided staging. This is indicated when you are looking at a potentially resectable disease or somebody with unresectable disease, like how we have discussed the kind of cases that I have mentioned earlier. If somebody has done a CT initially elsewhere and is coming with small mediastinal lymph nodes, but you do a PET-CT showing bright uptake in those lymph nodes. Here you can clearly see the size versus uptake discordance, and that is when we need to rule out if it is some kind of lower respiratory infection or some kind of pulmonary tuberculosis that has gone into the mediastinal lymph nodes. There you need mediastinal staging before proceeding with your definitive chemoradiation. Or if a patient has a large primary, for example, somebody has a T3 lesion, but with disproportionately small mediastinal lymph nodes, this is where you want to determine that the patient is clearly unresectable, because here the primary as such may be resectable, but your mediastinal lymph nodes would determine whether the patient should undergo a surgery or should receive chemoradiation, or in some cases should receive an induction chemo plus immunotherapy followed by decision on surgery versus definitive chemoradiation. Now, how did the treatment landscape in unresectable? Now, our focus entirely will be on unresectable non-small cell lung cancer. So, if you look at the evolution of treatment, the one of the early trials, or there was a meta-analysis which suggested that if you compare radiation versus chemotherapy plus radiation, concurrent, there was a clear-cut overall survival benefit. I have not mentioned the study or meta-analysis in my presentation. That is where the role of chemotherapy concurrent with radiation came into picture in stage 3 non-small cell lung cancer. One of the earliest used regimens were etoposide plus platinum. Now, this was compared with paclitaxel plus carboplatin in this particular trial, and it was found that there was no overall survival difference between the two regimens, and paclitaxel carboplatin had proven to be much less toxic as compared to uh, uh, etoposide plus platinum. Okay, this is another trial. So there, it was established that the role of paclitaxel plus carboplatin as the chemotherapy regimen of choice in patients with unresectable non-small cell lung cancer. There was another trial. I think the slides got missed. So it was again a comparison between pemetrexed cisplatin versus paclitaxel carboplatin, and again it showed that there was no difference in terms of outcomes in the patients. Then you have neoadjuvant chemotherapy plus immunotherapy followed by CTRT. So this is another approach which is kind of gaining momentum of late. This was studied in a phase 2 trial called Keynote 799. In this, initially patients were given one cycle of induction chemotherapy plus pembrolizumab, followed by concurrent chemoradiation along with immunotherapy, followed by maintenance immunotherapy. So immunotherapy was continued all through the treatment in all the three phases. This here the patients were categorized into two cohorts: A, which contained both squamous and non-squamous non-small cell lung cancer, and cohort B, where only non-squamous non-small cell lung cancer were included. And cohort B patients received pemetrexed cisplatin as the chemotherapy regimen. Now, if you see, the progression-free survival was much better as compared to chemo radiation alone. Though there was no straightforward comparison here, since this is a phase 2 trial, and at the end of 48 months, the the progression-free survival was 38%, while in cohort B it was 46%, which contained those who received pemetrexed cisplatin and who had adenocarcinoma. Even overall survival at 48 months was 54.7%, which is unheard of in patients with unresectable non-small cell lung cancer. My apologies. Earlier, I have mentioned wrongly that this trial, as the one which studied the role of chemotherapy plus radiation, it was actually it had actually studied the role of neoadjuvant chemo followed by chemoradiation, and showed that there was no benefit of giving neoadjuvant chemotherapy in patients who are for chemo radiation. But even in such cases, we still see our radiation oncology colleagues requesting for induction chemotherapy in certain situations, which may be because of disease-related factors or in some cases patient-related factors. This is a long list, but to summarize, the patient-related factors include those who are not fit for dual modality therapy upfront. The patient may have huge disease burden within the lungs. Patient may be tachypnic, performance status may be poor, nutritional status may be poor, patient would already be having COPD, so overall lung function is poor. In such cases, you are skeptical about the tolerance to dual modality therapy simultaneously. So in such cases, we are requested by our radiation oncology friends to give neoadjuvant chemo or induction chemotherapy, followed by response assessment to see how well the patient has improved overall, and then take the patient up for chemoradiation. Similarly, when it comes to disease-related factors, as I was mentioning earlier, if somebody has a very large volume disease that entails large area of exposure to radiation, that is one. Second, somebody with involvement of critical structures such as pericardium or spinal cord or esophagus. These are the organs where we don't want high doses of radiation to happen, radiation exposure to happen, and in such cases we have to give some form of induction treatment and then take the patient up for chemoradiation depending on the response. It is also important in some cases to see what is the disease biology, because you are ultimately offering some kind of definitive treatment. For example, somebody has undergone a CT scan elsewhere last month and his workup has taken 1 month's time, and the patient reaches you with a PET-CT report. And from the baseline CT scan to the latest PET-CT, if you are seeing a significant increase in mediastinal lymph node disease burden or in the primary tumor size, it indicates that the disease is of aggressive biology. And in such cases, you would want to give a test of systemic therapy to see how well the patient is responding to your treatment, and then take the patient up for chemoradiation. Now, let us look at some of the chemoradiation trials. Uh, this is the landmark PROCLAIM study, which looked at pemetrexed cisplatin versus etoposide cisplatin, which used to be the erstwhile standard of care for chemoradiation. And it was found that pemetrexed cisplatin is much less toxic and had equivalent or equal overall survival outcomes along with radiation. And from there on, pemetrexed cisplatin became the standard of care for patients with adenocarcinoma in CTRT setting. Then you also had another trial which compared weekly paclitaxel carboplatin with etoposide cisplatin. And again, this trial showed there was no significant overall survival difference between the two. And weekly paclicarbo is much well-tolerated regimen. And this established the role of pemetrexed cisplatin or paclitaxel carboplatin weekly as the standard chemotherapy regimens for definitive chemoradiation. Then came some of the studies on adjuvant chemotherapy after CTRT. Unfortunately, both studies, one studied docetaxel plus cisplatin and the other one looked at docetaxel alone. And both studies came out to be negative with higher risk of toxicities as compared to placebo. If you see, so far only induction chemotherapy failed, adjuvant chemotherapy failed. Only definitive chemotherapy has been positive in this journey of, or in this evolution of treatment so far. Now comes the first landmark trial, which is PACIFIC, which established some form of adjuvant systemic therapy to be showing overall survival benefit in patients who receive definitive chemo radiation. And this was basically a comparison between durvalumab for 1 year versus placebo, and it clearly met all its endpoints, both PFS as well as overall survival. You could see that at the end of 60 months, the overall survival among those who received durvalumab maintenance was 42.9% versus 33.4%. This so far what remained a challenge for the investigators or trialists to show survival benefit with added systemic therapy was broken by this trial. Now, if you also see certain nuances in this trial which are very important for our day-to-day practice, when we look at the subgroup analysis, those who received radiation adjuvant durvalumab within 14 days after completion of last radiation, they had better overall survival as compared to those who received durvalumab after 14 days of completing chemoradiation. And you can even see the difference in hazard ratio, which is 0.39 versus 0.63. So it is that important to notice. It is that important to start the maintenance durvalumab at the earliest after completion of chemoradiation. And the practical point is that durvalumab being an expensive drug, most of the patients may not be affordable to begin with. So in such patients, it becomes important to discuss the initiation of durvalumab at a particular within a particular time frame at the beginning or at the earliest, even during chemoradiation phase itself, so that the patient can arrange some finances and you can start the treatment at the earliest. Then post discontinuation, if you see, patients among durvalumab arm, only 12% of the patients received subsequent immunotherapy upon recurrence. And in the placebo arm, patients received 29% of the patients received 29% of the patients received subsequent immunotherapy. And what about the role of durvalumab retreatment among those who received maintenance immunotherapy? So this was an analysis that looked at those who received durvalumab for 12 months at least and did not have disease recurrence during that phase, and then went on to develop recurrence later on and received durvalumab again. In such patients, if you see median time to second progression, it was 48 months. And these were very few patients, only about 34 patients went on to receive retreatment with durvalumab, but still you could see that subsequent immunotherapy rechallenge was giving significant overall survival benefit. This suggests that you can still offer immunotherapy in patients who are recurring after 12 months of durvalumab once they go on to develop recurrence. This is about timing of chemotherapy in patients receiving immunotherapy consolidation. Now, there are two concepts. One is sequential chemoradiation and the other is concurrent chemoradiation. We clearly know that in small cell lung cancer, sequential chemotherapy, that is, you give radiation first and then give chemotherapy, it showed inferior survival outcomes as compared to those who received concurrent chemoradiation. Now, there is no direct evidence as such in non-small cell lung cancer, but if you see some of the trials, this is specific trial which did not include any patients who received sequential chemoradiation. All patients received concurrent chemoradiation, and this was the 2-year PFS percent. And then there was another trial which is Pacific 5, which again studied durvalumab. And here you can see that here they both sequential chemoradiation and concurrent chemoradiation patients were included. And clearly you can see that those who received concurrent chemoradiation had superior 2-year PFS as compared to those who received sequential chemoradiation. Then there was a real world study of durvalumab. Same as that of Pacific, but here again you could see patients who received concurrent chemoradiation had better 2-year PFS percentage. Then you had a Chinese trial called Sugemalimab, wherein the same was looked into, the same aspect, and it was clearly found that concurrent chemoradiation should be the preferred approach in patients who are planned for adjuvant or maintenance immunotherapy. Then this was another study which looked at giving immunotherapy even during chemoradiation phase. In Pacific trial, we looked at giving immunotherapy after completion of chemoradiation, and now this is along with chemoradiation, immunotherapy was given. And unfortunately, this did not show any overall survival or progression-free survival benefit, but it came with significant short-term toxicities. That is within 4 months of completion of chemoradiation, patients with grade 5 adverse events, which means death, were significantly higher in the durvalumab plus chemoradiation arm as compared to those who received only placebo along with chemoradiation. And this sealed the fate of uh, giving concurrent durvalumab along with chemoradiation. But in an earlier study, which was Keynote 299, which we looked at, it was a phase 2 trial. There, pembrolizumab was given even along with immunotherapy, but there no significant increase in toxicities were noted. That was basically because of smart patient selection, wherein they chose those patients who had better performance status, who had better lung functions, and also those who had smaller volume mediastinal diseases, thereby reducing the risk of especially the pneumonitis. Pneumonitis was the commonest cause of death in these patients who received concurrent immunotherapy along with radiation. That was avoided in Keynote 299 because of smart patient selection. And this also highlights the fact that while designing a trial, it is important to choose the right patients for your trial. Then there are various trials which looked at escalation of your adjuvant immunotherapy. So far, we saw giving neoadjuvant chemotherapy which failed, adjuvant chemotherapy that failed, concurrent immunotherapy which also failed. So only successful strategy so far has been giving maintenance immunotherapy or adjuvant immunotherapy only. Now, escalation of adjuvant immunotherapy is the upcoming strategy. If you see those who received nivolumab plus ipilimumab after completion of nivo plus chemoradiation, when they were compared with those who received nivo chemoradiation and only nivolumab in the adjuvant phase, there was no survival difference. Again, this was a disappointment. So adjuvant escalation to dual immune checkpoint inhibitors was a failure, and you also should see the fact that these patients had a significantly higher study drug toxicity, those who received adjuvant Nivo plus Ipi as compared to those who received Nivo alone, which was 16% versus 7%. So it was more than double in these patients. The reason why this was a failure. So this is the summary of immunotherapy trials. You had Pacific 2. If you look at the phase 3 trials only, you had Pacific 2, which was concurrent Durva plus chemoradiation followed by Durva, which was a failure. Then you had Pacific, was the only successful trial in this setting. Then you had Checkmate 73L, which was adjuvant dual immune checkpoint inhibitors, which again was a failure. So this has been the journey so far with only one successful trial, which is Pacific with maintenance durvalumab alone. But there are upcoming treatment strategies, various treatment strategies, which are mainly focusing on escalating the adjuvant immunotherapy phase. Now we have looked at a CTLA-4 drug being added to anti-PD-1 inhibitor, but you also now are seeing the strategies which are combining anti-PD-L1 with TIGIT, anti-TIGIT antibodies. So this is one of the upcoming strategies. You also have other combination immunotherapies that are coming up in the adjuvant space. You have another trial called KeyLink, which is a phase 3 trial, wherein the combination of olaparib plus pembrolizumab in the adjuvant phase is being studied. But the preliminary results have shown that the addition of olaparib did not add to progression-free survival benefit. But this is an interesting space that is emerging with each day with newer treatment strategies that are coming. We are failing repeatedly, but still we are in the pursuit of the right choice for adjuvant immunotherapy so that we are able to prolong the survival over and above what we have already achieved with Pacific. So what works? That is concurrent chemotherapy as the curative treatment works. Then you have validated concurrent chemotherapy backbones, which are weekly paclitaxel or pemetrexed cisplatin for non-squamous cancer. Then you have a Pacific trial, which established durvalumab and completion of chemoradiation plus consolidation. What doesn't work? Adjuvant chemo or neoadjuvant or induction chemo, then concurrent immunotherapy. So far, there is no role, and adjuvant escalation to dual immunotherapeutic agents doesn't work. With this, I conclude my talk. I hope I could cover this space comprehensively, and over to organizing team. Thank you.
Thank you, sir. Thank you so much for your talk. So, without any further gap, we'll move on to our next session of the day because of the time constraint. We now begin our panel discussion. It's my pleasure to introduce our moderator, Dr. Ashwin Oman Philip, professor at Amla Institute of Medical Sciences, Thrissur, with a strong interest in thoracic malignancies and multidisciplinary cancer care. His clinical and research interests include solid tumors, immunotherapy, precision oncology, and advanced cancer care, with active involvement in clinical trials and peer-reviewed publications. So, joining Dr. Ashwin on this panel, we have Dr. Suma Devaraj, a consultant medical oncologist from Solapur with expertise in systematic therapy for solid tumors. Her clinical interest includes delivering practical, patient-centric oncology care in real-world clinical settings. Next, Dr. Subhashish Mohanty, a senior consultant histopathologist, some Ultimate Medicare Bhubaneswar with extensive experience in oncopathology. His expertise lies in accurate pathological diagnosis and its role in guiding personalized cancer treatment. Next, we have Dr. Manikandan Dhanushkori, a director and consultant medical oncologist at Tinmani Hospitals, Toothukudi, with vast experience in comprehensive cancer care. His focus includes delivering integrated oncology services and improving access to quality cancer treatment. Next, we have Dr. Rupanvita Biswal as a consultant pathologist at Bagchi Sri Shankara Cancer Center and Research Institute, Bhubaneswar, with specialized expertise in oncopathology. Her area of interest include gynecological, genitourinary, breast and thoracic malignancies with a strong focus on advancing cancer diagnostics. And lastly, we have Dr. Sanjeev Kumar Mishra, sir, the Director and Senior Consultant of Radiation Oncology at Utkal Hospital, Bhubaneswar, with extensive experience in advanced radiotherapy techniques. His clinical focus including optimizing radiotherapy outcome and integrating radiation with systematic therapies. I now hand over the session to Dr. Ashwin sir to begin the discussion on real-world challenges in lung cancer management, practical decision making in Indian settings. Sir, over to you, please.
I want to thank the organizers for giving us this opportunity. And without wasting much time, I would like to invite all our panelists. Can I share the screen from my side?
Yes, sir, please, sir.
Right. So, one second. Is the screen visible?
Yes, sir. Now it's visible.
Right. So, like rightly said, I'll be focusing more on a real world scenario, and we all work in different institutions with different modalities that we have with us and the challenges we face in a real world. So, with that, I'm presenting this man who was a 65-year-old male who had presented to us with a history of cough for around 2 months duration. And he had an X-ray done outside, and then he was evaluated outside and the CT scan, and then he came to us. So, by profession, he was a school vice principal, was a reformed smoker for more than 10 years, had a history of tuberculosis in 2005, and had a peculiar family history on the paternal side where there were a lot of people having malignancies. On examination, he was extremely fit with a good performance score of ECOG of 1 and a left-sided reduced agony in the chest. Otherwise, there was no other findings on him. When he came to us, because we were working for malignancy, a PET scan was done, which showed a left lower lobe lesion, which was around 6.5 and 6.2 centimeters. And this was seen extending into the pleural fat, and there was a hilar lymph node and a left inferior pulmonary ligament lesion. So, with that, I would put up the question to Suma ma'am, in your center, when a patient like this comes, what would be your protocol approach and how do you go about managing this patient?
There's a PET scan report with a large left lower lobe mass with mid-spinal node involvement also. First thing I would like to get done is a tissue diagnosis. So either a bronchoscopy biopsy or a CT guided biopsy would be my first approach for this patient.
Okay. I also want to put up that question. Dr. Manihan is not there, so I would ask Dr. Sanjeev sir, when it comes to you, would that be your main approach? And would this patient go for a biopsy first or an MTB discussion before you plan the biopsy?
Histopathology proof is required before proceeding to any of the treatment or even the protocol, because you need to go for a molecular study nowadays. Without molecular study, even in stage 3 also, you can't treat. You can't. This is like if you see such a big lesion with a more nodal burden, maybe you are not going for surgery. So that is why your molecular histopathology and molecular things are required.
Okay. So this patient, what we did is the patient, we have a pulmonary medicine department that they did an EBUS and they did a CT guided lung biopsy as well. So before this patient was actually taken up for a plan, the first day in the OPD itself, we had a mini MDT because there were a lot of discussions. This patient being a school principal had connections. So we had to make I had got the surgeons involved, the radiation oncologists involved right at the beginning to make so that everybody's on the same platform. So what we had is that we had this EBUS and a biopsy and a CT guided lung biopsy. Now coming to the pathologist, Dr. Subhashit sir, this is what we got upfront. We had this thing of non-small cell lung cancer, and Dr. Upanita Biswal ma'am, with this report and the fact that I had limited tissue. So there was two issues here. Like most of the time in lung cancer, that venous channel evaluation got me a very scanty tissue. It showed me a venous channel lymph node involvement, but the lung tissue is what I had left with. So what is the minimum IHC and what would you look for in such patient? Dr. Subhashish sir? Dr. Subhashish?
Actually, yes. Am I audible?
Yeah, you're audible.
Okay. For this, we have to go a minimum panel of minimal ISC markers like CK7, TTF1, and P40, so that we can we can distinguish between adeno and squamous. And if the pattern if the pattern is that of the neuroendocrine, then we can go for a synaptophysin to add on.
Okay. So, uh, okay. So with this report,
I
would
just
you
want to
still?
add on one thing. Can I add
Yeah.
on one
Yeah,
thing,
please,
please?
ma'am. Please, ma'am.
Yeah, so what we actually do in our lab is, since tissue is the issue in lung, everyone says. So what we do when we go for an HE cut, during the cut section only, we take more sections for IHC on a simultaneous go. And just we
Okay.
start, this what we have 5 unstained slides when we do a HE stain, so that we save the tissue at the same time. And we just start with TTF and P40, and then we keep rest of the tissue if it is required at all for any other IHC. Thank you.
Okay. So what we had here was something else. We had a CK7 positive, and rest of the markers were negative. And this got us into a slight fix because we were already a bit delayed at the entire picture. Patients get anxious most of the time. So, from a pathology point of view, could both of you, Upandita ma'am, what else would you do in a situation like this?
So actually, many of the IHCs are done. I would like to add at least a synapse, not just for small cell carcinoma. Yes, the morphology is not at all a small cell carcinoma, but for a large cell neuroendocrine carcinoma, at least to exclude large cell neuroendocrine carcinoma. But rest, I think it is being done.
Fine. Anything else other than the synaptophysin? Dr. Subhashis, sir, anything else you would like to say? So this patient had that done as an addendum report. So this is the first report that I had was this. What was said was that they couldn't identify markers for adeno and squamous, and they just gave it as a non-small cell lung carcinoma. So how often do we get into such a situation? The addendum report is there, after which they had done synaptophysis was negative, but how often in real world do we get such a situation? And then what do you do about it in such a situation? Dr. Subhashish, sir, are you there? If not, Dr. Kufanida, you could take this up.
Yeah, so it is not very common, but yes, we do get this kind of cases in our lab. So in this scenario, we'll always try to rule out first if it is a mets from any other side. That is a first go. But considering PET CT, it's not showing any other tumor. We have to consider a lung primary in the current scenario, and just of course report it as non-small cell carcinoma (NOS), and would definitely consult the clinician to send it for NGS rather than wasting the tissue for further IHCs. That would be more helpful, I think.
Right. So, to Dr. Suma, right now we have a diagnosis of a non-small cell lung cancer. Can I confidently say that this has a very less chance of being by any default a small cell? So that was ruled out. And Dr. Suma, in your institution, for this patient, would you plan a mediastinal evaluation?
Yes, sir. Considering large size of primary and PET scan is showing uptake in the mediastinal nodes.
So the PET scan did not show uptake in the mediastinal nodes. So how would you evaluate the mediastinum in this patient in that case?
So
The hilar node was involved. Yeah, it was involved. Yeah.
feasibility of bronchoscopy guided biopsy from the mediastinal lymph node, I would like to discuss with the pulmonologist.
Okay.
And I would also like to involve the surgeons if EBUS is not feasible, then mediastinoscopy
Okay.
and biopsy.
Yeah, so that in a real world is a bit of a tricky scenario. I mean, taking him to the OT, all those things are real world tricky. Sanjeev sir, in your institution, the mediastinal evaluation, so that N1 was not an issue as far as we were concerned, because that is close to the region. It would have been a pathological node. We do the biopsy for the mediastinal node for sure for two reasons. One is to confirm. Second thing is, in this case, the N1 was not worrying me. Why we do a biopsy of the mediastinal nodes is sometimes we pick up tuberculosis. Off late, we've been having issues with CA breast, the doubtful patients who have this T3 lesion having mediastinal node, whether it is TB. So we've had pickups where we would have had tuberculosis. So that is one reason. But in this case, why I'm asking particularly was the surgeons who had sent it to us were very keen on taking this guy for a surgery.
So,
Reason.
don't get biased by the PET report. But if you see
Exactly,
the
yeah.
report here, if you see the PET report here, the SUV value is around 23 or something. High
Yep.
in uptake in the PET. That is the one. Second thing is that, see, there are 2 stations are involved, no?
Yes.
So this case, definitely, if the upper station is, if you are getting a negative on biopsy, maybe you can think of surgery. So that is the thing you need to exclude actually. So that is what maybe you need to do a mediastinoscopy or a EBUS, whatever. You need
Yeah,
to do
so we had done an EBUS, and that I mentioned that they took that segment from that for the film. So the question now is, what is the stage? He would be at T3, and then EBUS was positive, and this is where the issue came. So in the tumor board, as we were discussing, we were thinking whether it is N1 or N2. The issue was that when the pulmonary ligament is involved, it is in the inferior mediastinal node, so it becomes N2. So then it becomes typically what we would say as a single station N2, that is an N2A on an imaging, because there were no other lymph nodes on the EBUS evaluation, and this was the only thing that was positive, and the HiLA node was there. So then it became a T3N2A. So at that point of time, we had a fix because this patient has an NSLC, which is undifferentiated, and I had sent the tissue for an NGS by the time to avoid a delay. So to the pathologist, recently somebody came and met me and said, we can do an NGS and give you a report within 42 hours, 48 hours. There is this fast NGS option. Can somebody enlighten me on that and how valid it is and how good it is? Dr. Subhashish or Dr. Rupanita?
Yeah, so rapid NGS is something which actually in my setup we are not encouraging currently, but yes, there are some labs who are doing rapid NGS, but authenticity I really don't know. I really don't have an idea of the authenticity of rapid NGS. But whatever you have written is a liquid biopsy and circulating tumor DNA, that is a better option. A comparable option to biopsy if we are not getting a good sample in a biopsy or we are dealing with scanty tissue. Liquid biopsy and circulating tumor DNA can be assessed from the plasma or from the pleural fluid cell block.
So how different is the liquid biopsy from the circulating DNA?
So
Actually, sir, I just want to interrupt. Sir,
Yeah.
what is the need for liquid biopsy here? If the tissue biopsy is adequate in the sample, because I see the images, the tissue biopsy is adequate. So what is the need for liquid biopsy? And this rapid NGS is not a standard. Actually, in many setups, this NGS is given a proper timing. So rapid NGS is just there are many flaws in rapid NGS. So many centers are not advocating this rapid NGS. And liquid biopsy, when the tissue sample is adequate, there is no need for liquid biopsy and circulating tumor DNA. So
Okay,
minimum
yeah, so
50 to
the rapid NGS I had put
50
up
to
because
Huh?
in this case it is not an urgency, but can you hello?
Not an urgency.
Yeah, in this case
Yes,
it's
it
not
is
an
not an
urgency.
urgency.
Yeah. So there were two things. Recently, we
No
had a
urgency,
patient who
yeah.
was sick in the ICU and for whom we had to plan a treatment. So at that point of time, we did discuss this. So I just wanted to know from a pathologist's point of view the role of the rapid NGS, because it is something new to me as well.
Liquid biopsy indications are those patients who are very sick, those patients where the biopsy is inapproachable, those patients where the lesion is nearby the blood vessels, major blood vessels area, and those patients where the initial biopsy specimen is very scanty. Scanty means where there is less than 50 number of cells for pathological evaluation for NGS. That are the criteria for going for liquid biopsy.
Okay, Dr. Rupanita, do you want to add something to that?
Sorry, no, I don't want to add, but just some points in contrast to what's told is like, suppose we are seeing biopsy is adequate. Sometimes we face it in our lab that we give the biopsy, we feel it is adequate, and we keep on saying this is adequate, but we get a request from the molecular side, no, the tissue is not inadequate. But as sir told, he's right that even if only less than 50 cell is called inadequate, otherwise it can go for a
So
adequacy
what
test.
about tissue heterogeneity and the fact that sometimes on that specimen you may not find what you were looking for? So isn't that something that happens very
Yes.
rarely?
Yes, I
So
do
in
agree
that
to
way,
that.
would a liquid biopsy help you to pick up something that is thrown into the circulating DNA that, the added mutations which you would probably, that is what has been discussed sometimes I've
Yes,
heard in meetings.
yes. I
So
do
would it
agree to
be,
that point. Tissue
yeah, so this,
heterogeneity is there.
especially in a
Considering
case
we
like
have
this where we were not sure whether it was adeno or a
yes,
squamous,
exactly. So
would it
considering this
be,
case as a large cell non-small cell carcinoma NOS, this could be anything. So
yeah.
I mean, there could be many areas where which we are dealing and we are not able to pick it up. So in those cases, liquid biopsy can be helpful. And other time you were asking me about the difference between circulating tumor DNA and
Yeah.
liquid biopsy.
Yeah.
So basically, liquid biopsy includes circulating tumor DNA, but also liquid biopsy has, that pleural fluid is also a type of liquid biopsy. So but circulating tumor DNA, when you're talking in particular, it shows the plasma. We collect the blood and plasma, and then from there we get the circulating tumor DNA. That is.
So would you use a circulating DNA to
And
monitor this patient's response rather than as a diagnostic tool?
yeah, I mean, even the disease progression is these days are being done through circulating tumor DNA.
Yeah. So that is what I wanted to check here. So coming to the next slide. So like I discussed, for us, this then became a T3N2M0. And the surgeons right from the beginning had said that they could go for a surgery. But because in the tumor board we discussed, because it was an N2A, and the fact that he had all these issues, we said we should start chemo first and then reassess him and take a call by the time we get all these reports. So to Dr. Sanjeev sir, I mean, many years back when I passed out surgery, I mean, I hardly saw anybody getting operated for lung cancer. So throughout my 3 years in residency in Adyar, I never saw anybody getting operated for lung cancer. So I always thought anybody who had a mediastinal lymph node or a hilar lymph node automatically went for CTRT. So there was no concept of surgery, because one thing is that it was difficult to do surgery, so most of the patients were not fit. So in your practice and your experience, have you seen treatment evolving in lung cancer over the last 10-15 years? Dr. Sanjeev sir?
Here, if you see, like stage 1 disease, we get hardly any.
Yep.
Hardly. So this type of cases usually we see. Stage 3 disease we see. But again, after stage 1, most of the time they are inoperable. When there is
Yep.
an end disease, in 99% of the time it is not operable at all, unless it is a single station and the surgeon wanted to operate. That's very important thing, because usually these are the complicated cases. You need to do a scopy, mediastinoscopy or EBOS, find out whether it can be done or not. Again, it should not be bulky. It should be less than 3 centimeter. So, other than that, so the N2 diseases are those diseases with the potentiality to have metastasis. No, maybe it may not have metastasis in the beginning. Maybe post-operatively, unless you give some sort of adjuvant therapy, systemic therapy, they will have metastasis. So that is why in highly selected cases of N2 disease only you can operate. You cannot operate in all cases. Very rarely you will be able to operate. But that is what, if in this case, if you are planning for surgery, thinking that yes, your surgeon is ready to operate, maybe it needs certain other maybe a downstaging of disease, only you can go for a whatever. But if not planning for surgery, probably these are they are fit for the durvalumab type, concurrent CTRT, immuno or whatever.
So in your setup, would you in your tumor board fight for a CTRT durvalumab approach, or would you say
I will prefer that, because see, thoracic surgery again is not that much developed in these places that you are go for a mediastinoscopy and do all this thing, and later on maybe post-operatively you have a metastasis there somewhere. So that is why I personally feel it's better to start a systemic therapy. If you are planning for surgery, if you are not planning for surgery, then go for a CTRT followed by durvalumab. That will be a better option.
Yeah, so we discussed this case extensively in the tumor board. There's a lot of missiles thrown up and down from both sides. So, and this is the first time that we were actually going to give neoadjuvant for any patient. So we had not given neoadjuvant immunotherapy for anyone. So at that point of time, we discussed and we said the surgeons were keen for surgery. The patient wanted surgery. He was fit from a surgical point. It was a single station N2 disease, otherwise fit patient. So we said, okay, we will try neoadjuvant chemo. The only problem is that when I started the first cycle of chemotherapy, I did not have the NGS and PD-1 report. So because of that issue, we started the first cycle on paclitaxel carboplatin. This was discussed in the tumor board and everybody was involved. And this patient, particularly because it was the first case that we were doing planning for a surgical approach. Traditionally, yes, I would have gone for a CTRT approach for what I was trained, but this was particularly similar because the bus showed only one lymph node, the inferior pulmonary, which was picked up and biopsy proven. So once this was done, my question to the pathologist is that because of financial issues and the fact that we have coupons now, we always stick to the 12 gene panel with the PDL1 testing. Does doing a larger panel make sense, or does it just complicate the scenario altogether? So, Dr. Subhashis, sir, do you recommend doing extensive panels for lung cancer, or just stick to the 12 to 18 gene panels?
In our setup, we do only EGFR all cross and PDL1 and this NRAS. These are the panels, minimum panels we do. So I don't think there may be other panels recommended by other medical oncologists, but my medical oncologist is comfortable with these panels.
Right. Dr. Rupanita, are you okay? I mean, the 12 gene panel is because the coupon has a 12 gene. So it is easier for us to do. We just have to send that coupon and it's done free of cost. So that's how the 12 gene panel comes up. Would you want to add anything here?
No, so the 12 gene panel should be sufficient with PDL1, but considering this non-small cell carcinoma NOS thing, if a patient can afford, I would prefer a 50 gene panel. If patient can afford, I'm adding it again. Because
he could afford because of the fact that we were planning immunotherapy on him. So there was no guns lost in this case. But again, I was worried about how much I should stretch my gun in a patient like this. And the fact that we were already, he was getting irritated for everything. And I was testing him one after the other. So
twice for the panel, it's better to send it one go if patient can afford for it, and so that we see the co-mutation or some uncommon mutation present.
So would that have changed my treatment was my worry. And so Dr. Suma, what would you do in a situation like this? Would you hold your gun and say 12 is enough, or do you say let us go for 500, 600 and see what we can shoot in the dark?
But sir, considering that we are going for a surgery in a non-metastatic setting, I think 12 genes should be enough, because treatment management we are not going to change. But also one significant thing in his family history, there are lot of cases in the paternal side. So maybe that is the only reason.
So you would think of BRCA. So that was one thing I discussed, and we discussed, I talked to him about. So they were already upset there were too many things. And then I said, let's do a germline testing. And he flipped at me at that point of time. So then I said, we'll talk about it later. So I was highly confused. And at that point of time, to be very frank, I didn't want to lose the patient. So I said, I'll do this expensive test free of cost for you. And then we'll take a call based on that. So that is how I'm being very frank. This is a real world scenario. And I used that to keep the patient with us. And we got the testing done. Meanwhile, I started I used Paclitaxel as the first cycle. And it was decided that we will try for a surgery.
Yes, so I've got you for a couple of things. One is as you are again one of our academic council member. So I would like, as you accepted to be one of the academic council member, so I would like to know you are still pursuing that breast, lung, and gynec, if I'm not wrong. These are your major area of interest. And
whom are you talking to right now?
Okay.
Roshni, you're online.
ఓకే మ్యామ్. సో ఇప్పుడు మీరు మేజర్గా 3 ఏం చూస్తున్నారు మ్యామ్?
Roshni, you're online.
ఓకే మ్యామ్. ఓకే. బ్రెస్ట్, గైనక్, లింఫోమా.
I think we have some interruption. So I'll just try to call her and say that she's online. Right. So this plan was concurred, and the NGS report came. So this NGS report showed you, we used the TPS score, and in the NGS score, we had a PD-1 of TPS score of 8, and the NGS showed a TP53 mutation. So is everybody happy, Dr. Suma? It was neither here nor there.
But more than one, we do consider it as positive. But
that is my saving grace.
And even otherwise, it doesn't impact the selection of treatment. So
no, it doesn't. It doesn't.
This should be okay with us.
Should be okay. So I also took the saving grace because this patient went to the tumor every time because the full hospital is watching us. I had to fight with the cardiothoracic surgeon saying, don't operate upfront, give me some time. So There's a lot of pressure from that side as well. So this is what it came. Sanjeev sir, are you okay with this? And to the pathologist, yeah, Sanjeev sir, once your take on this.
The only thing the NGs are getting TP53 positive, no? So probably that patient is not going to respond well to chemotherapy.
Okay, so the TP53. So this thing I am very curious about. So whenever this NGS shows TP53 positive, in all the national tumor boards, everybody will say, let us give chemo, immuno, let us give add osimertinib to immunotherapy. But what TP53 means, yes, it is an aggressive histology, and this patient probably will not respond as well. But escalating therapy to what extent, I'm not very sure. Because if you look at all the previous studies that were done, all the studies with the EGFR and all, they would have had enough patients having TP53 positivity also. So, I mean, I don't know how much escalation, it is a bad prognosis, but how much escalation will really change the thing, because you don't have a comparative arm to say that escalation versus no escalation, these patients have not done well enough. So I get upset when people say that just because TP53 is positive, we have to add osimertinib with chemotherapy. That anyway, the data is there, you can add, that is definitely there. But by not adding it, just because it's TP53, I'm not very sure. So that is what my concern is. And to the pathologist, my question is, now this entire thing of PD-1 testing has become very funny, because from TPS to CPS, now there's a TAP score. I'm not able to understand the difference between a TAP score and a CPS score. I mean, I know that the TAP score looks at the spatial arrangement, and I'm sure that it is being done so that you can get more patients who are positive. That's how the companies push for these things, because the more you have 1% positivity, the more you can push for the drug. So if Subhash sir and Upanita can enlighten us about the TAP score, and how does this thing make it different?
Yeah, so TAP score is basically the tumor area positivity, whereas the CPS or TPS score is tumor proportion score and CPS is combined proportion score. So when TAP is something new right now, and here what we see the area of tumor which is taking positivity, not the percentage of cells which we see in TPS and CPS. So CPS is basically the percentage of tumor cells we are seeing, but in TAP score, we are seeing the area of tumor cells which is taking positivity. Basically, it's a kind of eyeballing thing, we call it in our pathology ward.
So that can have interpersonal variations, is it?
Yes. Yes.
Actually,
Because
so wouldn't the
sir,
CPS score, yeah.
To be very specific, sir, the drugs which are being drugs means immunotherapy which has been planned for this lung carcinoma is based on TPS score, and there are 4 categories. It is less than 1%, it is between 1 to 4%, it is between 4 to 49%, and more than 49%. That's how the category is done. And TPS is basically the viable number of tumor cells divided by total number of tumor cells. PD-L1 positive tumor cells divided by the total number of positive tumor cells into 100. The percentage is calculated like this. So we are just familiar with the TPS because the clone which is used for pembrolizumab, our medical oncologist uses that. So I am quite familiar with TPS rather than other scoring.
Yeah. So the newer immunotherapy approvals look at the TAP score. All these Chinese molecules that have been done, they have most done the studies are done mostly looking at the TAP score. But if you look at the traditionally lung cancer, it has always been TPS. It is in the other cancers where CPS has come up. But the newer studies that look at this have looked at a TAP score.
This TAP score is not validated with CAP. The College of American Pathology, this TAP score is not validated till now.
Okay, so that is an important point to note. Yeah. So with that, this patient had the NGS ready. So what we did is we decided to go, because from the beginning we had primed this patient, and because we had started paclitaxel, I put him on second cycle. I don't use steroids when I use nab-paclitaxel, because anyway using expensive treatment, then I don't want to take a risk of dampening the effort. So I use nab-paclitaxel here. Dr. Soma, would you do the same? I know that there's a bit of a controversial thing, steroid and all those things in. So would you do the same, or would you still give steroids in these patients and continue with the pacli-carbo?
Maybe lower the dose of steroids, sir, because nab-paclitaxel, but yeah, affordability is not an issue. So changing to nab-paclitaxel is a good idea.
Yeah, because the thing with the steroids is you need to pre-medicate him if you're going to use nab-paclitaxel, and you have to give post-medication. For me, is that if I'm using an expensive drug, I don't want to blunt that effect of that drug by, I mean, because it's not a trial anyway, so I don't want to blunder. So I said, I mean, patient was comparatively cooperative for whatever it was. So so the problem here is the checkmate study looking at neogen chemotherapy had 3 cycles of induction chemo immuno, but here I had to taper it because I brought in the immuno in the second cycle. So we gave 1 cycle of chemo and then 3 cycles of chemo immuno. He sailed through it, not much of an issue. This is a PET scan. It showed me a good response. So I was actually very happy. And, in the tumor board also, I was smiling all the time. But for me, the problem came is 2 days before the surgery, the wife came rushing to my OPD saying, there is disease progression and you have goofed up our case. So it was a bit stunning. I was in the OPD and I was sitting there and I was taken back completely. So what happened is that there was a good reduction. Everything was there. But they did a pre-operative bronchoscopy because the cardiothoracic surgeon said that he found something near the hilum, which is not reported in the CT scan, and there was a bulge in that near the secondary carina, and then it was a huge bomb all over again because you've used a new therapy, you've given him immunotherapy. It was the first case in the hospital, and everybody was after my life. So the question was, should I have done a biopsy? If I did a biopsy, would it change my treatment plan? So this was highly controversial. I remember sitting at 6 o'clock with the cardiothoracic surgeon and the pulmonologist and saying, if you're going to operate. Because in my mind, somewhere down the line, I thought pseudo progression could be there, even though it was, I mean, lung, we don't see much, but it could have been there. So the problem here is that the cardiothoracic surgeon told me that, yes, I will take him for surgery, but it will be a pneumonectomy, not a lobectomy. Dr. Suma and Dr. Sanjeev, did we fail because of that fact that the entire concept, if you look at it, is the fact that if you, literature says that you could, the purpose of doing all this would be to try to see if you get a lobectomy. It's like BCS versus an MRM or whatever it is. So at this point of time, for me, it was a big heartbreak because this guy would end up with a lobectomy, which traditionally would have been a bad prognosis in terms of his survival. So did we fail or not was a huge question. But the cardiothoracic surgeon said, with this report, I will not be able to do a lobectomy. I need to go for a pneumonectomy. I didn't tell the family much about it. I just came off. But what would your thought be? Did we fail this approach, Dr. Sanjeev, sir?
Lobectomy, pneumonectomy depends on the cardiopulmonary reserve and how much of the lung you can resect it out.
Okay.
And really, if you are planning, it's a immunosensitive tumor, no? If you are planning for a surgery, maybe lobectomy will be enough. No need to go for
here. The problem was that bulge was near the carina, secondary carina, left carina, and the surgeon said he will not be confident of doing it because he said because of that lesion, he wanted to take off the full thing. So I had no other choice but to agree to it because at that point of time, I was the victim and everybody was saying that it would have been upfront CTRT or it would have been upfront surgery would have been a better option.
It might be like if you are showing that in the bronchoscopy, if you go back to the PET, I think there is a partial response, a significant regression of the tumor. So
there was, but this thing had come up, sir. This metastatic, this was not there in the previous bronchoscopy.
Probably this is not a tumor, Prof.
Yeah, so this is what I fought for, and we said, lucky, let's go for the surgery. And he went for the surgery. My thought was, should I biopsy? Again, it will delay the treatment, progression, pseudo-progression, whatever it is, we said, go for the surgery. Now, when we went for this surgery, what was surprising is that inferior pulmonary ligament that was initially positive was negative. The subcarinal lymph nodes were negative. The only one lymph node that was positive was the hilar lymph node that was there for the beginning. That too, the size had come down. So it was a T1C N1 from a T3, clinically T3 N2 disease that had come down. So yes, to the pathologist, does this now constitute a major pathological response? Not a complete pathological response, but a major pathological response. Dr. Rupanita and Dr. Subhashish?
I would not call a major pathological response, but yeah, that's a near, I mean, not a complete, also near complete response, I can say. But
what is the definition of a major pathological response?
No, because I'm seeing the tumor size is like, initially it was 6, I remember.
6 into 5,
Yeah,
6.5 into 6.5.
5. Yeah. So now it is 2. So at least it has reduced to like 1/4 or 1/3 of the size, 1/3 of the size. And then a tumor, as you said, there was no node positivity in the this subcarinal or something
Yeah,
which was
inferior
there
pulmonary. So what
previously. Yeah.
happened is that the tumor had actually grown near the bronchus actually. That is what happened.
Uh,
So it was like a pseudo progression actually. It was not a progression. So the tumor had grown into the bronchus. It was not the node that had grown.
yes.
Yeah. So with this report, I was a bit satisfied, but I was upset that he had a pneumonectomy done. So the question now came is, if he had achieved a PCR, I would have slept in peace. Dr. Suma, what would you do at this point of time?
Since he still has 45 to 50% viable tumor, continue with the adjuvant immunotherapy.
Yeah. So the problem is at that point of time, I got into a bigger problem with the PAP for the approval for nivolumab was in India was just for that neoadjuvant phase. Now for me to give him adjuvant, and because I had already registered him as neoadjuvant, I was in a big fix in this game because I did not know, they didn't tell me about this game because I thought it was taken for granted. When I applied for the adjuvant, they said, you have already applied for neoadjuvant, and in India, the approval is only for neoadjuvant. He will have to pay for the rest of the cycles. And that was the biggest thing for me. Again, patient was willing to take treatment because in my mind, it was 10 cycles and 5 cycles and then free. This again shook me very badly. So, I mean, I learned it the hard way. And the fact that the adjuvant could have been given, we discussed, and the PAP and the fact that when to start treatment. So this guy, luckily for him, he had to go back. So he was teaching in the Gulf, so he had to go back there. And the dose of nivolumab in the adjuvant is 480 mg every 4 weeks. So that again was a problem. So I gave him the first cycle of adjuvant at 3 mg per kg, and then I sent him to the Gulf to somebody whom I knew. Luckily for him, he had an insurance running there, and that insurance was able to cover his treatment. So he got the 480 mg nivolumab from there and is continuing it there. Now, the same question that you asked me at the beginning, does that strong family history worry you? It worried me. And should I have asked for comprehensive genetics testing? I did ask. They were not willing because in India, there are a lot of things that happen. The families, the daughter's wedding and all those things. So they didn't want us to really relieve any of those things. So they said they don't want to take the treatment. They don't want to go for that treatment. And I was also tired by, there were so many bombs in this case that one more bomb on the NGS, I didn't have the guts to face it. So, I mean, I didn't push for it, to be very frank. I should have, but I didn't push for this particular patient because I was not sure what I would get and how I would manage that part of the game. Dr. Sandeep, sir, would you have pushed for a hereditary screening in this case with your experience with so many years? Would you have pushed for a hereditary screening?
Getting a strong family history, maybe we should go for that, ideally.
Yeah, so my worry was whenever I'm asked for these tests in off-label indications and I get off-label reports, then again I take it to the tumor board and then everybody stares at me saying, this guy orders a lot of tests without rationale. So, which was my, I mean, to be very frank, because I'm in the tumor board every week and I'm presenting all these things. So I was, by this time, because this PAP issue had come up and the family was stuck with the PAP issue. So I didn't push. I did tell them and document the file, but I didn't push that. I mean, I was not confident to push for it. So right now what he is he met me last week and he's an adjuvant nivolumab, completed 5 cycles. A PET was done from the Gulf when he had come to meet me on a visit. He is in complete remission. I don't know how long it will last or how long this honeymoon is going to last. But this is one of those cases where it was my first experience trying a neoadjuvant approach, because traditionally I've always been CTRT followed by consolidation or no consolidation sort of an approach. Let's see how it goes. And is there anything else you want to discuss? I'm open to discuss. And I want to thank all the panelists for the patient listening and for everybody in the audience for patiently listening to this discussion. Thank you.
Thank you.
Sir, actually, I have one question. I mean, just mind.
Yeah.
Well,
Yeah,
so
please.
is it like, do you have a different treatment plan when it is a poor response or a partial response or a complete response for the?
Yeah, so if there was a complete response, I wouldn't have given him adjuvant.
Okay.
So the entire thing in this lung cancer is that you have this 24% patients who get a complete response. Now, for that 24% is what you're aiming for.
Yes.
But having said that done, the pembrolizumab study and the subsequent nivolumab study went in to give nivolumab. Okay,
Yes.
but the thing is, in an Indian setting, when you don't get a lot, so then it becomes cost effective. You give 3 cycles of immunotherapy, uh, you can stop at around 6 lakhs. But if you the adjuvant again becomes cost effective because if you take 5 cycles, then it is free for another year. So the logic then sometimes doesn't make sense, right? But this patient, if I had got a PCR, I would have had a better sleep because the fact that I would have thought he would have had a better cover. But the fact that he's got a family history may point more, but he was a smoker. So that is one thing that is there. I was if the BRCA comes positive, it makes my life a mess because I don't know what conservation I'll do on this guy, how I would screen him because this itself is going to be difficult. So that was my worry. Yeah. So the treatment approach, the only thing is if it is an adeno, I would have used a PEM carbo approach. Here the problem was that I was not sure what I was dealing with, so I played it safe by giving a nab-paclitaxel carbo. Adeno would have given me a pen carbo approach, sort of a thing. Other than that, not much. But the fact, what I like in the entire thing is that surgery, we would probably see more of these cases in times to come. Because what I see is that the pulmonologist or the physician in the periphery, when you have cough for more than 1 month, automatically will ask for a CT scan. So I think the number of patients that you see like this is going to increase. I mean, it's not like in olden times that they would wait. 1 month patient is not responding, automatically CT scan is done most of the time. So I think over a period of time, the previous tumor board only I told my consultants, see, we will have to learn to manage these cases because by the time in another 10 years, this will be our bread and butter because I don't think this will come up in big numbers because everybody asks for a CT scan, a PET scan will be asked immediately, patient will be sent to us. So we will have to learn to manage these sort of patients because in 10 years, this is going to be standard to see for at least 40%. I may be wrong, but that was my discussion. So these challenges make it, I don't know how he'll respond, but so far so good. We'll take it from there.
Was it in the resection? Sorry to interrupt. Was it in the resection? Did they try another TTF because of the tumor heterogeneity or something? Did they see any adenomorphology or did they try any
So
IHC
so the second resection by the time this report had come and he had come to me, he wanted to go back to the Gulf. So I wanted to do an IHC in the second resection. So the pathologist again told me the thing is morphologically it remains the same. And he said he wanted to take the tissue back because the treating doctor over there had to have his tissue over there. So he took the tissue because when I was taking this case again, I asked the pathologist, do we have tissue to do this again? And they said, you only gave the order to release the tissue, so we gave it to him. But what we had discussed that time was the fact that morphologically it remained the same. And again, it is not going to change my treatment plan because of the fact that
just to interrupt, sir.
Yeah.
Actually, in the initial setup, what the ISC has been done, I think it is very inconclusive.
Yes,
So
it was
because
inconclusive.
it was not very conclusive because there are some variants of lung carcinoma which are TTF1 negative, P63, P40 negative. So we have to get the diagnosis right through ISC. If it is in the initial core biopsy, the tissue is a issue there, but in the second resection specimen, we have to get the tumor diagnosis proper or correct by adding some immunomarkers. There are some variants
Yes,
of
I
lung
agree.
cancer, that is enteric adenocarcinoma, fetal type of adenocarcinoma, which are only CK7 positive, or mucinous adenocarcinoma, which are only CK7 positive. But rest all TTF1, P63, P40, these are all negative. So we have to get the diagnosis correct. If we don't get the diagnosis correct through ISC, and analyzing and interpreting the ISC is a challenging thing for the pathologists who are doing oncopathology especially. So that is the first thing. Then we can go for molecular anything. First thing is you have to get the markers right and get the diagnosis right through ISC.
Dr.
So
Suma,
I
your
think
take on
the
that?
enteric type has a morphology which we can at least pick up, but then yes, there is something called large cell carcinoma, and which is which
So
Large-
can
my
be
question
possible and
is,
can be
would it have made my treatment plan different?
Yes.
No.
Sir,
Treatment.
actually it will be
So,
different.
Sorry, sir.
It will be different, sir.
In what way would my treatment plan be different, sir?
Sir, it will be type of adenocarcinoma, so it will be different.
Yeah, so it would be a type of adenocarcinoma, and the NGS was negative. So for me, actually, if he's got to relapse, he would relapse. There's no question about it at that point of time. But the reason why he was going off, so we were not going to treat him treatment for here. That is one reason I had to push for it. But the fact that technically would it have made a difference in my treatment? From an academic point of view, yes, it was important to test. There's no question to see if that changed, and I was sure what I was dealing with, which is very important. But from a treatment point of view, as of now, my treatment is not going to change unless it picked up a mutation which was not there upfront.
Yes, that's true.
Yeah, but
That's
that
true.
is highly unlikely because then the tumor heterogeneity question that I asked usually comes up important.
Sir,
Should I have done
is
separate
there-
liquid
No,
biopsy would have been better.
Sir, I have no doubt about the treatment plan, but being a pathologist and a oncopathologist, we should get the diagnosis correct. That is very important.
Yeah, I agree to that. So that was my thought. So yeah, that's one way of looking at it, and my way of looking at it was that at this point of nothing was not going to change my treatment, and circulating DNA was liquid DNA was not done in the beginning, which maybe I could have done, but again, he did well, he's doing well, so I kept quiet. Let me be real world scenarios. This is the truth. I mean, I'm an academic center, I teach my kids, but some cases are tough, especially when they're paying from their pockets. Was my issue. But yes, I do take that point. That
Actually, sir,
for it.
the tumor cellularity is 40 to 50% means it is just a partial regression. It is not a complete regression at all.
Yeah.
So
No,
tumor
we're not
cellularity
expecting
is
complete. It's not a complete regression, sir.
yes,
It's not a complete regression.
yes, sir.
Right.
I just had a question, like, any reason why you chose carboplatin and not cisplatin, sir?
Mainly it was a toxicity, actually. It was a toxicity. So the reason is, again, yeah, so that point of time, the initial part was a bit tricky. The initial time, because I was not sure whether he'll go for resection and all those things. And my thing is, when you're using a good drug like immunotherapy, so the same question I'll ask you is, in your real world practice, when you treat TNBC, what regimen do you use with your Paclitaxel?
Sir,
Do you use a weekly Paclitaxel or use a
weekly,
3 week?
weekly,
Sorry?
pack-
So
weekly
use a
pack-
weekly Paclitaxel. So again, it becomes very, very difficult for patients to come every week, and then the 3 weeks of Pembro. So I'm collecting my data, which I hopefully would come up in some time. So I use a 3 weekly Paclitaxel, and the responses are just as good. Yeah, I should have used cisplatin, but you need to understand that I was under so much of pressure in this patient that toxicity was also a big worry as far as I was concerned. Yeah, so this is learning for me. I mean, like I said, there was no right and wrong when I was doing this case, and that's why I put it up in public to see what are the opinions that come up and to see what is it. So yes, I should have used this. I didn't because I didn't use it. I don't have an
I
explanation for that.
think the nivolumab trial allowed both cisplatin and carboplatin.
Yeah, so I played it safe. I mean, I remember read it in detail and I played it legally safe for whatever I could. But again, I am not very confident using cis because where I was trained traditionally, cis was never used. So that was also one problem where you're trained that creeps up in your blood at some point of time. So I didn't use cis. I used carbo because of the other reason. Yeah.
That training part, even I am not so keen on cisplatin in most places, sir. Like carboplatin, we are more used to it. The toxicity we can predict more.
Yeah, so that's the main thing. So here I think I read because it's when you deal with these tough cases that you do a little bit of extra reading and play it safe. But I remember reading it and I thought that'd be fine. Yeah, so this is good. I really enjoyed it. I hope it was not boring for everybody. And it was nice having all of you together. Thank you.
Thank you so
Thank you,
much.
sir.
Thank you.
Thank you all. Thank you, Dr. Ashwin, and all our panelists for such a stimulating and highly informative discussion. So, as we come to the end of today's session, I would like to thank all our faculty members for their valuable time and IR for organizing this enriching academic program. Thank you to all the participants for joining us today. We hope this session was informative and engaging and clinically relevant. Thank you once again. Have a wonderful evening. Thank you all.